All right, Teresa, I think we can get ready, and thank you everyone for joining.
All right, so one of the things I want to talk about is the fact that sometimes we just don't know our terms. I've added some here, just some basic ones, just so you can take a look at them. I'm not going to go through everything. And I do believe that you were given a glossary as one of the handouts. It's a great thing to go through and look at this. Sometimes just knowing that the verbiage helps out a lot on this test.
Joined.
So axomesis and neuromesis and neuropraxia, those are all kinds of injuries. You should know those guys because there will be questions that ask about that. Temporal dispersion. This is an example of temporal dispersion. Some of you may or may not see this. A lot of times you see it in a focal lesion, such as carpal tunnel or ulnar neuropathy at the elbow. So it's nice to know what these things look like and what they mean. We're going to talk about demyelinating neuropathies. There's both inherited and acquired. Inherited, this is an example of one. If you notice, everything is just slow, but the whole thing looks very nice and similar. So this would be just a form of CMT. It's important to know that because if it's acquired, that's when you see temporal dispersion like this. And it's patchy, so not every nerve is slow, or every piece of a nerve is slow. These are all things that might be asked so that you can determine whether this is a localized lesion or if it's a generalized process going on. I just wanted to throw this in. This is a teased nerve fiber. This is actually what segmental demyelination, so GBS, this is what it would look like if you took the nerve out and actually got to see it. These ones here, I don't know. Do you guys see my mouse or no? Yeah, look right here. This nerve here would be a totally demyelinated nerve. This one's still got a lot of myelin on it here. And then all these are different stages. It's just nice to be able to see or know what you're seeing here. Wallerian degeneration, again, these are terms that you really need to know what it means. So sodium pump, as far as sodium pump goes, you need to know what goes in and what comes out, which way the potassium goes, which way the sodium goes. I put next to the side that sodium goes out and the potassium goes in. Solitary conduction, this is another one. It's how, our stem moves
Joined.
one node to another. Active transport, resting potentials. You guys can look at these and go through them. They'll be very good for you. Neuromuscular junction. You need to know what you see when you're looking, and you want to know what you're actually looking for. So if you have a case that you think is a presynaptic, which would be a botulism or a LEMS case, your CMAPs, so your motor amplitudes, are all low. If you're looking for myasthenia, your amplitudes are normal. With botulism and LEMS, besides the low CMAPs, you may or may not have a decrement with your 2 to 3 hertz rep stem. What you do have is you have a facilitation with these guys. You just exercise them for 10 to 15 seconds, or if they can't exercise, this is when you do rapid rep stem. And as you see here, one response, all you have to do is exercise 10 to 15 seconds. It goes from abnormal to totally normal. With your fast hertz, look at this. If you only go out 4 or 5 responses, you're going to miss this. You really need to go out 10, 15, 20 things. Ours is set up so we can look at every one that we've actually done so that you can see how facilitation
joined.
Botulism looks a lot like LEMS, only the facilitation tends to be less than 100%, and LEMS tends to be greater than 100%. Myasthenia gravis, you have this nice normal CMAP, but you get a decrement when you do your 2 to 3 hertz rep. You do your 4 and 5 things, and you see it go down. You exercise, now this is important, you exercise these guys much longer, 30 to 60 seconds, and you get your repair. And if you went out, if anyone's been reading, you see the books where it says you can go out immediately after, 30 seconds, a minute, 2 minutes. 3 minutes is where you see your biggest decrement. So if you're good, you would do before exercise, immediately after, and then wait your 3 minutes. And this is what you get. You get this nice little decrement here, and then everything goes right back to the same after your exercise. You need to know a little bit about age-related things. For infants, about half of what an adult is what you're seeing as far as conduction velocity. It can take up to 3 years for a child to sort of catch up. And of course, if they were a preemie, it makes it even harder sometimes. Anomalies. Everyone needs to know, A, how to find an anomaly and what you're looking for. So median ulnar or Martin Gruber is the most common that we see. Remember, a quarter of the population out there has these. So one of the things you do is you get your response at your wrist, looks nice, everything like it should. And then if you notice, if you go to your elbow, you'll see this little dip. This is a clue that you actually are bringing something else in. It's larger than the other one, so when you go over to the ulnar to stem, you should turn things back down, so duration should go back down. You don't want to do it at 0.2 or 0.5 because then it's just volume conduction. And you'll notice there's a dip here too. So it says that I'm picking up from something that's not over where my recording electrode is. So you put this and this together, and that's how you get your proximal. The other thing you should be aware of is if you happen to have a carpal tunnel, sometimes you get a super fast conduction velocity. And when I mean super fast, I mean it's like physiologically impossible to have this. It could be 100. So having a very fast velocity should be one reason why you would go in STEM to look for a crossover. Just your amplitude larger than your proximal larger than your distal should be another reason. And if you have this little dip, it should make you think about it. Perineal accessory is kind of nice because it all looks the same, but when you go, so once your proximal is greater than your distal, and you go where you normally record for your Searle and do a little stim there, the response you get adds up with your distal response to be equal to or greater than your proximal. So that one makes lots of sense. Sometimes your Martin Gruber, it looks like if you add them together, you have a conduction block, but you don't. So there's one in the hand. It's ulnar to median. It's just Rashad. You're not going to see this very often, but it's at least something to be aware of. Blink responses. I don't know how many of you guys actually do blink responses, but you should at least be aware of how to do them and what they look like. So this is in through the 5th nerve and out through the 7th. On your responses, you get an R1 on the side you're stimulating and an R2 on both. So the setup is here. You have your recording electrode right below the eye, and you can put G2 either at the corner of the eye, or you can do the opposite side of the nasalis. And you set both of them up the same, and then you actually stim at the orbicularis notch. This is a response. This is a normal response. You can see here, this is your R1, and then here, all this junk is your R2 coming back out. And that's what you want to see on them. If there's a problem, you could have R1 could be gone, or one of your R2s could be gone. But if you have everything set up right, this is what you should get. Late responses. Late responses are the things we see all the time or do all the time, hopefully. It's just a matter of recognizing some of these. So this particular is your A wave. So if we would take this and superimpose it, these would become one just like your M's would. It would look like you just have one response. So if something is in the same place, has the same amplitude, the same latency, do not call it an F wave. This is usually between your M and your F, but the truth is it can be anywhere along the line, and it's just evidence that sometime in this person's lifetime they have had some denervation and some reinnervation. Doesn't mean there's something abnormal now, but there was something abnormal in the past. F waves, hopefully we all know how to do an F wave. Perineals, I think, are one of the hardest Fs to get. If you look at these, amplitudes look different, latencies look different. So just make sure that the characteristic is there for what you're looking for. H's, I don't know how many people do H's. H's are, in my opinion, very nice to see. Not always as useful as we'd like them to be. They are supposed to be useful when it comes to S1 radix. I've seen them totally normal in S1 radix, and I have seen them gone in just people who have had injuries to their back in the past. When we're born, we have these things everywhere.
Joined.
So when you do this, you're going to use a very long duration. Whatever your machine has, if it's 0.5, your highest, that's what you want to use. If it's a 1 millisecond, that's what you want to use. And then you're going to start really low. If you notice, this starts at 10 milliamps. And you go up pretty slow. This went from 10 to 20 to 25 to 30. You see the H starting to come in. And then you start seeing the M wave. As your M gets larger, as you increase your stimulus, your H actually goes away. That's a perfect example of an H wave. The other thing is if you do a little bit of a rapid stem, so repetitive stem, it can make the H go away. Anatomy. People forget some of the anatomy they need. So you need to actually look at roots, the nerve you're doing, and then the plexus, what trunks or cords is coming from. And the truth is, we have a set of flashcards that have all of that information on, so it's a great way to study. So you need to find a nice plexus. This picture is kind of busy. You don't have to use this picture. What you need to do, though, is you need to find a nice plexus that you can study from and look at. You can use some of them in some of the books that we have. Median sensory. So you need to know it's C5-6. It's upper and middle trunk. Those are the kinds of things you need to be aware of. Always know the setup, because any of those questions can be on your test. Ulnar sensory, same thing. You want to be able to identify all those things, because those are things that can be asked. Motors, sensories. So another really big thing is what you actually see. People look at responses every day. I don't know if you guys actually don't look at what you're seeing, but little things like this is what mess some people up. I'll take questions in just a minute, Arshad. So here, you have shock artifact. This is, a good thing to ask people, and people miss it when you ask them what this response is. The other thing is how you measure stuff. We would like you to measure things. We'd like you to know that you can go, you have your sensitivity here, you have your time base here. If I ask you to tell me how big this response was, you could at least estimate. So there's 20, 40, probably it's not 30, maybe 25, 24. But you guys should be able to give an estimation, and that estimation will be close to one of the answers on the test. So you need to make sure, if you've not done this in the past, you need to do this a couple of times with some of your responses that you get every day. And the same with your latencies. So 2 milliseconds, that means from here to here is 2 milliseconds. So your onset's definitely 2. Your peak here is, maybe 2.5, 2.6. You should be able to do this within a 0.1 or 0.2 millisecond thing. So, and look at there. We're at 45 and 2.5, 2.4. So you would be very close if you estimated those things. You should try this yourselves. Go back in, remove your markers, and look at it, and then go back and see if it's what it was. These are the easy things on your test, and it's things that you guys, I'll be honest, it's things that people tend to miss. So Anna, are people not getting sound?
Urshad, did you call into the meeting as well? I'm wondering if maybe he didn't log into the audio portion, so I'll message him here.
Well, there's another one too. Anita says she's not getting sound.
Okay, they'll just need, I'll put the call-in numbers on the audio or on the chat here for them.
Okay.
I'll get that posted.
For the rest of you, this is just a motor, the same thing. Where's your onset? How big is your response? Whether it's, whether we're asking for a distal or a proximal, you should be able to do this. Anything we ask like that, all your information will be there. You'll have whatever the milliseconds are. So pay attention, because we might have put it to 5 or 10 even. Make sure you pay attention to what your settings are and what your sensitivity is. Those are the things you actually want to, we all get excited when we take tests, and the problem with that is we think we know what something should be, and then we miss it because we didn't look very well. So, actually doing conduction velocity. You should be able to figure out a conduction velocity on your own without using any kind of machine. It's fairly simple. The conduction velocity is distance over time. When you're doing a motor, you need 2-point stems, so you have whatever your distance is. And I'll be honest, here in my lab, we do them in millimeters, so that our 1 millimeter falls away and we end up with meters per second. And then we take our latency too, so this is our proximal latency, and subtract our distal latency, divide those in, and we get our velocity. Asking you to figure out a velocity will be there, and you guys should be able to do this so that you find it, the correct answer on the exam. Not trying to be tricky about any of this, just want to make sure you guys actually know what you're looking at as you see all of this stuff. You should know some of the diseases. Now I realize maybe some of you don't see all of this, so I put some of these down. When you look at an anterior horn, you have ALS, you have polio. When you're looking at a muscle disease, you certainly have a myopathy. A nerve disease is a radic or a mononeuropathy, or even a generalized peripheral neuropathy. So from diabetes, that would be a nerve issue. If you were looking at somebody who had polymyositis, that would certainly be
joined
myopathy category. There's some of these on your guys' study guide, and you can certainly look in a reference book, and it will talk about this, but you should have an idea of where some of these diseases are actually coming from.
Joined.
So temperature's a huge issue. As you can see here, if I'm cold, I have a very slow and a much larger response than if I'm nice and warm. For most people, now this person, you probably wouldn't care because everything falls within normal limits. But if this person was outside the realm just a little bit and you warmed them and made them normal, you would want to know they're truly normal. The other thing is there is no disease that gives you a really large amplitude with a prolonged latency. Sensory nerves are affected way more than motor nerves. And the other thing that's affected by your temperature is if somebody's cold and you're doing a rep stem, you can actually make your rep stem look like it's normal. And if you're looking for myasthenia or something, you want to make sure they're nice and toasty, because if they have a decrement, that can save people from having to have a different kind of test altogether. So the other little things we want to always make sure we look at is we want to make sure that we look at our regular electrodes, but we want to make sure we look at how our stimulators are set. I know nowadays most of them you can flip your anode and cathode, but not all of them do. You still want to remember which is your negative and which is your positive. When it's flipped around, it changes your latency. So when you're taking the test and they have pictures and they have this kind of stuff up, make sure you look and see, is something like that switched or not? Does everything look like they belong right where they are? That'll help you. We want to have an idea of how far away we want our recording electrodes. If you notice here, someone just raised a hand. Who just raised their hand?
The conference has been unmuted.
Hello?
Does anyone have a quick question? Okay, I'll put it back on mute here for just a few more minutes, and then we'll take some other questions here at the end as well.
The conference has been muted.
You notice 2 centimeters apart, I get a pretty little amplitude. I go between 3 and 4, and I get a very nice, healthy amplitude. If I go greater than 4, my amplitude drops again. Again, this is one of those things that we got to be a little bit cautious about, because even though this one dropped, it's still within, as far as we're concerned in my lab, this is still within normal limits. So we wouldn't necessarily call somebody abnormal, but if we did this one, we would start saying that people are abnormal. So we want to make sure we have those electrodes in that sort of sweet spot. Filters. So there's a couple things with filters. I do believe you guys got a handout on filters also. What you really need to know is you need to know, what do filters change? Do they change the amplitude? If they change the amplitude, how do they change it? Do they make things bigger? Do they make things smaller? Do they make things faster? Do they make things slower? And you have this little blurb that's in your study guide, and then that handout actually talks about that kind of stuff. That is what you're really looking at when it comes to filters. So if you can know that and make yourself a sort of a cheat sheet, a little chart that talks about what makes what faster, what makes what slower, Does anything make anything bigger, or does it always make it smaller? If you know those answers for filters, you guys will be golden. And just a hint, nothing makes anything bigger. So we have some resources. I don't know how many of you have this, but this is one of the books that's put out through the AANEM. This is a very nice book designed for techs, and it has little things all the way through, so it's a nice, easy read. There's also the flashcard set that we talked about. That's also through there. As far as anatomy goes, anything that's in those cards are all fair game for you guys to be tested on. Now, when it comes to a big reference, everyone should have one big reference. I'm not telling you you have to buy these, but one of your docs hopefully will have one of these, either a Kimura or even a Preston Shapiro. And the goal is Preston Shapiro is a little bit easier to read, but Kimura talks about the nerve categories much better than Preston Shapiro does, like the Neuropraxia and the axomesis and neuromesis. And it's all within short paragraphs. Find somebody that you can borrow one of these from so that you can look at some of this stuff. You should have, within the glossary, it describes those things. If you even just go through there and pick it out from there, you will know enough to be able to take your test. I don't want you just to take your test. I want you to actually learn something so that you'll know this as you go through things. But it will be enough for you to get your test done. Do we have questions?
Let me get everyone unmuted here. One moment.
The conference has been unmuted.
All right. Can I ask some questions? I know, Urshad, you had a question. It might be easier to ask verbally.
You want me to ask the question? Hello? Can you hear me, please?
I can hear you a little bit. It's a little bit muted or a little bit fuzzy. Can you speak up just a bit?
I had my question regarding blink effect, ipsilateral R1 and R2 response, ipsilateral R2 response and contralateral R2 response. I had just a couple of days back, I just gone through the article which was sent by William Concern, which was mentioned over there that contralateral R2 response was earlier than the ipsilateral R2. Ideally, as I have read out Kristen, which mentioned contralateral pathway is compared to the ipsilateral R2, contralateral pathway is quite long in terms of distance, so it should be prolonged than the ipsilateral R2 cell. So can it be possible that a contralateral R2 response be earlier than the ipsilateral R2 normally?
Joined.
Occasionally the contralateral can be earlier than the ipsilateral. What you're looking for, though, is you're looking for if it's about 3 to 5 seconds delayed is when you have an abnormality.
No, in normal situation. What I mean to ask is
sometimes
normal situation, not in any abnormality. If normally, if we do a blink effect, can we have earlier response than contralateral R2 earlier than the ipsilateral R2? Can it be possible?
It can be. It's usually very close when it's a little bit faster. Neither of them are very far apart. What you're looking for is you're looking for big discrepancies between the two.
And one more thing,
huh? You have a 130. I know, I was going to check for it. Oh.
Do we have other?
I got it, honey. It's okay. Thank you, there.
Do we have other questions? I know I'm getting a little bit of background noise, so if you don't have a mute your.
So salty. Like, I love salt, but it's like beyond. Really? Yeah. Was it like a...
If we have other questions, we can certainly go back to other slides as well, if anybody wanted to go back and ask their question.
Is it possible for us to see, when you were counting the amplitude and the latency, I couldn't see like a mouse. You know what I mean? So I couldn't really tell as well what you were referring to on how to count it properly.
So I don't know if my mouse comes through or not. Do you see the pen at all?
The red, are you talking about the red plus sign?
No, that's a marker.
Oh, yeah, no.
But if you go from, so if you start at the beginning, so if you look where the plus sign is, you'll notice right along there there's a bunch of dots, right?
Yep.
So that's your beginning.
Okay.
And you go to the next dot. In this case, that is 2 milliseconds.
Are you saying the next dot to the right or the next dot up?
No, the next dot to your right. So
Okay.
we're doing milliseconds. So milliseconds is your time base, so it goes horizontally.
Yep. Okay.
And then we have a 20 microvolt is our sensitivity.
Mhm.
So you pick a dot. It doesn't matter which dot you want to start with. Pick a dot and you go up a dot, and that would be 20 microvolts.
I see.
So
It's 40 microvolts.
it's a little
with
over,
that.
but
Yeah,
it's
with the
not
tick
halfway
movement.
over that. So if it was halfway, it would be 50. So you know it's between 40 and 50, and it's probably maybe halfway between there, maybe not quite.
Mhm.
So, 45. So you give yourself a fair estimation of these, and the
Okay.
majority of the time, you are truly within, a couple of microvolts of these things. And we're not going to trick you. It's not going to be like we're going to say, is this 41 microvolts, 42, 43? We're going to say, is this 40? Is this 35? Is this, 50? Is this... So we're going to leave you a range there, and you should
Okay.
figure that out fairly easy as you do this, okay?
Perfect. I have a question too about protocols, or was that going to come in a little bit?
Go ahead.
Okay. So I know all of our labs have their own set of protocols, and I was wondering if there were going to be questions that say, if for example, a patient presents with, mononeuropathy or something, what should you do? Is there somewhere where there's kind of a uniform set of protocols that we should be memorizing for those types of questions, or will that not really be on there?
So again, everything that you just said is true, which means every lab has its own protocols. We won't necessarily ask like you to say what you would do if this was the question, but what we might say is you have this nerve, and this nerve that is absent. What would you do next? And then give you choices of other nerves. So say all your sensories in your lowers was absent, but your motors were normal. We would then ask you what you would want to do then. If we only said you did the sural and the superficial, chances are, hopefully you wouldn't pick any more sensories in the leg, but I suppose you might. But you want to go someplace where you think you'll find something. And that's what we're trying to get at. So say you were looking for carpal tunnel, and they said your median and ulnar sensory were fine. Is there something else you would pick? And then we would put on nerves that could help you define a carpal tunnel. And the goal would be for you to pick something more sensitive versus less sensitive. Does that make sense?
In that scenario, what would you choose? Radial?
Well, would you...
Radial would be more sensitive. So
it would be radial versus something, right?
Right.
So if that's a choice, absolutely. But you wouldn't pick the motors over a sensory, would you?
Right. Yes.
Okay. So that's the kind of things we would say.
Okay, because I know, like F-waves, for example, my lab rarely uses them, but then when I look at protocols from other labs, they use F-waves all day long.
Yep.
So
and
that's what I feel like is going to throw me, that stinking F-wave.
No. Don't think that. And, so F-waves are used because F-waves actually, F's and H's are both good indicators of demyelination. So people who see folks that have a lot of GBS or CMT, those F's are going to be prolonged. And for early GBS, it might be the only thing that's prolonged.
Okay.
So, they're not using it. Obviously, you don't care what it looks like in a carpal tunnel, right?
Right.
You don't care what it looks like in an ulnar, but you might care what it looks like if something's demyelinating.
Okay. That makes sense.
Okay. Corey?
Go ahead, Corey. You're unmuted.
Nope. Okay. Somebody else?
No, Corey put a question in the chat. It says, when discussing Martin Gruber variations, are the questions more focused on anatomies, such as MGA type 1, 2, or 3, or more focused on waveforms and troubleshooting?
There's a mix of all of that. Now, I don't really care if you can tell me if it's a Martin Gruber 1, 2, or 3, but I do care that you can identify a Martin Gruber and know where to go to tell it, so to point it out. There's a lot of anatomy because what do we do all day? We're doing tests on nerves all day long. So that is a huge part of the test. But we also need to know what we're looking at. How many of you find a Martin Gruber, and how often do you do it? I find them every week. Maybe not every day, but every week I find them. I do rep stem probably 3 times a week looking for different things. I realize not everybody does, but the goal is this is something that you should be aware of and know how to do, and then know, depending on if it's normal or abnormal, what you should be looking at and how to figure out if it's abnormal, what do you do to see if you can make it normal? And that's the important thing there.
1, 2, and 4.
You have other things?
So am I on?
Yes.
Okay. So the handbook, the AANM handbook, what do you think about that versus the checkpoint? Do you know what I'm talking about when I say checkpoints? Those little...
Yeah, I know what you mean. The checkpoints certainly don't have... They have some of that stuff in, but the truth is they don't have enough for you.
Okay, so focus on the AANEM handbook and the flashcards and then a Martin Shapiro or that other one?
Correct. And it can be Martin Shapiro. It can be Kimura. Some people I see were reading Dimitru. Dimitru certainly has a good reference. But what you need is sort of a big reference in comparison to the little handbook that you have from the AANEM. The little handbook is very nice. It's a little concise and stuff. But sometimes you just need a little more, and that's why you need one of those bigger references.
Yeah, because I noticed the picture in the brachial plexus and the checkpoint was limited, and then it was kind of messing me up when because it doesn't list like C8, I think. And so I was in the checkpoint anyway. So anyway, do you think it's beneficial to memorize the diagram of the brachial plexus as far as, I think the brachial plexus is kind of a big deal on the board exam, right?
I'll be honest, so when I took my boards eons ago, there was a handbook that I used from the organization at the time, and it had a very simple bracket for a plexus. And not only did I memorize it, but when I walked in to take my test, I actually put that down on my scrap paper and set it next to me so that after that I didn't have to worry about it. I could just refer to it.
Yeah, that's what I was planning on doing too. Okay.
So, because it's, there's a lot of things that will go back to that and it will help you out.
Okay. And then same for the lumbo and sacral plexus as well, I presume.
The lumbosacral are not, do a few things with that, not as much, right? One of the goals is if you have just motors affected and no sensories affected, that be a plexus, a sciatic, or a radic. So where would you put it in the scheme of things? And I hope you would go way up to root. Your senses are good.
Okay.
Does that make sense?
Yes.
Okay. Other questions? Rita, the book you can find.
Melinda.
Joined.
This book here, you can find it through the AANEM.
There's only one set of flashcards, correct?
Correct.
Okay.
All right, so I already have that book, the Nerve Conduction Study book. So
Okay.
is the flashcards online, and then it's just you go online and use them, or is it that they have to mail you the flashcards?
Anna, are they online?
It's a download, yep, so you can get it.
Perfect. Perfect.
Oh, is there a practice test?
There is not.
There's not. Okay.
The truth is the questions from your checkpoints that you were talking about are written similar to the questions that you would see. The format and the style is all similar to what you would see on your exam. If that's one of the things you want to use the checkpoint for, you could do that. But other than that, we do not have. And Anna, did we send any questions or not this year?
What was that?
And then we're just allotted a scrap paper to take into the test, correct?
Is that Jacqueline?
Background noise.
Yeah, if you guys are not speaking, can you mute your phone? Okay. I think I might have muted the right person there. Okay. Was that Jacqueline that you had a question?
I think I had a question, Kim. I was just asking that we are allowed to take in a scrap paper to the test, but that is all, correct?
Correct.
Yep.
As long as it's blank when you go in, you're fine.
And then I would expect also, is there going to be pictures, like diagrams, that we're then just labeling throughout the test?
No, there's pictures and they'll ask you questions, and it's still a multiple choice, so there'll still be, you have to pick the answer.
But it might be like a picture of like an action potential or something, and then we,
Certainly.
okay.
And then it'll point towards something, and it'll ask you, what they're pointing at or whatnot. It's one of the good reasons to pay a little bit of attention to all those things that you're seeing on there, because some of it is, the actual response, and some of it is just other stuff that we see every day. Like shocker effect or those things. So you want to make sure you know what's what. When it's an F, most people have a split screen nowadays. Can certainly, ask you off an F wave. It would not be. I'm just trying to go back to the F. Certainly would not be, if I had an arrow here and said, what is this? I'm hoping you guys wouldn't say an F wave. Right? It'd be the M.
Right.
So it's just a matter of what are you seeing every time you actually look at a response?
Okay.
It's not as, I realize it sounds like it's hard. It's not that hard. A lot of it is the fact that we all get very excited, including me, when we take a test. We want to get done as fast as we can, and we tend to hurry ourselves just a little bit. And so a lot of times what we're missing is the easy.
left,
But they do F like yeah.
So if you're not familiar with doing, some of these things, F's or H's, read about them. The books have them in there. Look at them so you can see what these things look like, so you have an idea of how they should be being done, what they should look like.
Okay. Yeah, the H reflex is something that my lab I've never done.
Okay, but Preston Shapiro talks about them. The little handbook talks about the H's. There should be examples of them in there, so you should be able to. Just from that, you should be able to answer the questions of an H wave.
Yeah, just knowing like what it is and all that. Okay.
And just that it's a little different than most nerves. Most nerves, you start really low and you work your way up. Those guys start with a long duration, then you start with your milliamps low and work up versus, a very short duration.
Okay. Oh, another thing that you mentioned in the very beginning, you said to know neuropraxia, temporal dispersion, and you mentioned two other terms in the very beginning.
Well, so in the beginning there was all the different terms. I just had put a bunch in so you could see. And I also said, you guys got the glossary now? Go through some of the terms. Terms is very important. So neuropraxia, it's a type of a nerve lesion. You want to know what this is.
Okay.
Axomesis and neuromesis, these are all different kinds of nerve lesions. And so you want to actually be able to figure out, like, who is the worst nerve lesion, who's the best nerve lesion. We all have neuropraxia nerve lesions. It's the best one you can get. It's compression, and the outcome for that is like 100%. So we all get better. And if you've ever crossed your legs and had the one go to sleep on you, that is neuropraxia.
Okay.
So those are things that you should know. You should know what kind of nerve lesion, because as you see these, if you actually did it and you got no response whatsoever and you got no movement, the chance of that person's nerve coming back is probably not very good.
Okay.
Okay. Other questions?
Irshad, do you have your hand raised?
Yes, I have just one question. Will there be questions from the portion of EMG, like spontaneous, normal, abnormal, or some MUAPs related, or even if about neuromuscular junction disorders, like single fiber EMG, like such questions will be there in the exam?
So in neuromuscular junction disorders, we're not necessarily, what we would ask is we would ask things that you would need to do to show that it's LEMS or to show that it's myasthenia. Or if we say, we exercise something for 60 seconds, what are we looking for? That hopefully you would say then is myasthenia. So the goal is with those things you need to know what you need to do as far as your rep stem goes, what each part of that rep stem would show. Does it show a decrement? Does it not show a decrement? If it shows a decrement, what do you do next? Those are the things you need to know as far as that goes. Does that help?
Okay. So that means what are the things which are associated with the nerve conduction studies all will be given, but like single fiber EMG, like jitter, blocking, whatever, we are not going to read these things because these are associated with the EMG again, part of EMG.
Correct. You're not. anything that leads to needle exam is not going to be asked of you.
Okay, all right. Right.
Anyone else? Mohammed? Mohammed, do you have a question?
Yes. Very good, nice presentation and good information. Actually, I'm asking how many questions will be in the exams and how much time will be given to us for that one?
Say it again, Mohammed.
How many questions will be in the exam and how much time will be given to us?
So it's 150 questions, and it's 4 hours, just like always.
And what percentage should be I have to obtain?
I don't have a percentage for you at this point. I have to see how things go. Sometimes we grade on a curve. Anybody else have questions?
If you do have questions that you think of later, you can certainly email them, and we will send them out to the group. So we'll just do kind of a blind copy of everybody on the response. So feel free to continue sending your questions. And you can just reply to any of the emails as well, and that should send the email to me with the question.
I think this has been really, really helpful, getting the emails and the webinar and that sort of thing. It's been kind of difficult. Most of us, I'm sure, just, we're doing a self-study, and so this has been really helpful. I appreciate it.
Yeah. Well, I wish you all luck. I hope to see all of you pass is my goal.
Thank you.
Angela, do you have a question?
Yes. You guys were referring to checkpoints. What are the checkpoints?
Well, there's checkpoints on the website. I don't have a link or anything, but if you go to ANEM and you go under Education for Techs, there will be checkpoints that you can do. I forget, Anna, how many do we have at the moment?
I believe there are 5 out there right now, and then they'll be adding more as we go. So completing 5 checkpoints will be kind of your way to maintain your certification once you pass the exam. So you could certainly use any of the checkpoints now to study it because they'll be creating more in the next few years through your certification cycle. So I can certainly send out a link to everyone with some of those as well if that's of interest.
And some of those, they talk about, I think there's a peripheral neuropathy, I think there's a brachial plexus, carpal tunnel. Do you know what the other...
Not offhand, but I'll send a link. Yeah, they're all different. They all cover different things. So.
Oh, okay. So, and some of the information is okay for the test, but the truth is these other things will probably give you as much as what you need.
Right.
So you could save the checkpoints to do after you've had it so that you keep your certification up. That's up to you.
Mm-hmm.
Anybody else?
It did in a way, because we have access to this so that these bulletins, so kind of, and we're going to have the recording of the.
Yeah. Yep, so I can send out the recording and the presentation if people would like. And then, like I said, you can always ask more questions as they come up as if you want to re-listen to the recording and then you have other questions, you can certainly email those as well. So.
Okay.
anyone?
I'm going to stick by my side.
Arshad?
Yes, I have one question regarding thoracic outlet syndrome, if you are going to answer me. Like if since it's the pathy and of the lower, can you hear me please?
Left.
I can hear you a little bit.
Yeah, since it's the pathy of lower
Left.
trunk and the involvement is most likely CAT1 predominantly primarily. So in nerve conduction studies as literature and so many others I have gone through, they have mentioned that primarily it affects CAT1 root. Also, obviously the sensory nerve conduction from ulnar like digit 4, half of the digit 4 and 5 will be affected predominantly, while the sensory nerves recorded from the median nerve will be most likely normal because the supply is obviously coming from C6-7 primarily. So it will not be affected. But as far as the motor nerve conduction is concerned, the median nerve motor response is getting primarily affected. Why is that? So why not ulnar nerve get affected primarily, motor nerve about?
Well, so you know that median motor is mostly C8T1.
Yes, exactly. It's the same for the FDI and ADM.
Correct. And
for
the
APD.
median
So
actually
why doesn't
to be a little
why
more
doesn't it get
8.
yes? Now, is there any specific reason to be affected, like a median gets affected first when it's motor, while ulnar gets affected later on?
For which disease?
For thoracic outlet syndrome.
So we don't know why thoracic has a tendency to pick on the median more, but if you notice the median motor, the ulnar sensory off the 5th digit is affected more so than the ulnar.
Yeah.
And we don't know if it's because it's pushing on that T1 a little bit more than it is the C8. But we certainly see that all the time. I don't think anybody has a good reason for why it's like that. Anybody else? Angela, do you have a question?
No, is my hand up?
Yep.
Oh.
I think that might have been
sorry.
No problem.
Okay.
All right, folks. If
Angela Sestito.
Left.
If you have no more questions, that'll be all for today. Thank you very much for coming.
All right.
Thank you.